In the wake of the September 11th attacks and the subsequent anthrax scare, a great deal of time and resources were rapidly invested in the public health system to respond to this crisis. In the process of preparing to respond to bioterrorism, we discovered that the skills we learned were useful in many emergency and disaster situations. We also learned that being prepared for terrorism or other disasters is not a one-time thing. It has evolved from being an acute problem into more of a chronic issue that needs to be addressed on a long-term basis. The question is, how do we incorporate planning for emergencies into a sustainable public health framework? We'll try to answer that question on today's episode of A Public Health Journal.
Welcome to A Public Health Journal, a program that explores public health issues facing our society today and tomorrow. The host of the show is Dr. Ed Ellinger, Commissioner of Health for the state of Minnesota. A Public Health Journal is sponsored by the Minnesota Department of Health and the Hennepin County Human Services and Public Health Department, all working together towards the goal of healthy people living in healthy communities.
Welcome to A Public Health Journal. Today we're going to look at the issue of emergency preparedness. That is, how do we develop emergency response plans at the federal, state, and local levels? And how do we train the people to respond in an effective way and maintain their level of experience? We'll be talking about that with a couple of experts in the field of emergency preparedness. But first, we'll start with a recent news report provided to us courtesy of KSTP Channel 5.
There was a field hospital set up at the Minneapolis Convention Center today. Medical professionals from across the state were triaging patients. It was all a training mission so that crews can be ready to roll when a disaster strikes. 5 Eyewitness News reporter Jessica Miles has a story.
Is everybody ready for scenario number 2?
It's the first time all of this equipment has been in the same place at the same time.
Is it getting better?
That seems to be getting better.
This vehicle is basically a hospital on wheels. Medical teams are training how to use it. The goal is to have this unit set up at the site of a disaster within 36 hours.
One of the things we worry about a lot is tornadoes. As we saw in Joplin, Missouri, a tornado can hit a hospital and a community can lose their medical care.
Over here, the ambulance strike team that can deploy multiple ambulances and crews anywhere in the state to take over 911 systems, help with evacuations, or shelter.
We have systems built in place that can be deployed quickly, efficiently, and timely.
Lanneberg says this huge coordinated effort can be set up anywhere in the state in a day.
This tent right here can be used as shelter, as a hospital, as an operations center. It can sustain 75-mile-per-hour winds. It has its own electrical, heat, and air, and it can pop up in less than 2 hours.
Large buses can become human transporters. One was used back in 2009 when the Red River flooded in Fargo.
We moved roughly about 180 patients in just under 6 to 7 hours once we got on site.
This training will help communities across the state.
Drills like this keep us very proficient and ready to go at a moment's notice.
But it's not only Minnesota that benefits.
We have been told several times that we have probably helped more states out than any other state in the country as far as our response capabilities.
In Minneapolis, Jessica Miles, 5 Eyewitness News.
The mobile medical teams consist of 2 different groups. One is based right here in the Twin Cities area. The other is in St. Cloud. Each group has more than 30 members. These are volunteers who all have day jobs. Their employers work with them to let them go on a moment's notice if they're needed at a disaster.
Joining us now to discuss emergency preparedness are Jane Braun, the Director of Emergency Preparedness for the Minnesota Department of Health, and Dr. Jim Harris, an emergency physician and Director of Emergency Services at Riverwood Healthcare Center in Aiken, Minnesota, and Medical Advisor for the Mobile Medical Unit and the Mobile Medical Team Project. Jane, Jim, welcome to our program.
Thanks.
Thank you. And it's nice having you on after this event that you had, this training program that KSTP kind of filmed. Jane, you've been in emergency preparedness for a while. Could we have done that kind of thing 12, 13 years ago, the kind of get-together that you had of all of those people and all of that equipment and all of this planning?
Absolutely not. Things have really evolved over the last 10 to 12 years, where we have built the partnerships, we've built the teamwork, as well as obtained the equipment and the types of resources we need and the training. And a lot of it we've been working on lately is the coordination. How do we know whose role is what? How do we bring in the things we need? And that exercise actually was the first time that we've ever had all of our mobile assets in one place to practice statewide with a lot of different teams.
Mm-hmm. So how did this come about? I know we had the September 11th attacks and we got resources to do that. And how did the planning actually happen to say, what do we need to do this, to make this actually come together?
Yeah, shortly after September 11th, there was a realization that there was a real lack of coordination of efforts and incapacity to surge the healthcare system and the public health systems. And so the federal government did give large grants to states at that time to start building this capacity and capability. And so we worked very hard to determine what the needs were and then to work on building on systems and resources and partnerships to take care of those needs.
Mm-hmm. Now, I mean, this all came about because of September 11th, but I have a slide here that shows, you know, what happened just recently up in Moose Lake, where we have the Moose Lake Elementary School underwater. This is an example. Jim, what are some of the things? You know, we're not just talking bioterrorism, you know, nuclear disaster. No. We're talking what happens in your local community.
Absolutely, yeah. There's, you know, obviously we see flooding in our state. We see tornadoes. There's plenty of natural disasters that can do this and put, you know, communities or healthcare at risk. But there are other more mundane things. You know, one example would be if say part of a hospital or a rural health clinic had a sprinkler malfunction and they lost a lot of their bioelectronics, lost part of their facility. That could put them at risk as well to be able to care for their community's healthcare needs.
Yeah, so preparedness is not just preparing for this major disaster. It's preparing for something that happens probably every day somewhere in Minnesota, somewhere in the United States.
Absolutely, yeah.
Yeah. Now I've got another slide, you know, because Jane talked about all of the resources coming together. So I've got a slide here that, you know, says, all right, we got public health as their role, and you got emergency management and healthcare. How do these all come together? To explain what's going on with the thinking behind this kind of Venn diagram.
Sure, what we're really looking at is what we call an all hazards approach, that it's not about a tornado specifically or about bioterrorism specifically. It's what do we need to do in the system, working with our different partners to be able to deal with any type of hazard that might occur. And as the slide shows, we're really trying to coordinate the things between public health, healthcare, and emergency management. We need to understand each other's roles. We need to use each other's assets. We need to have common language. We need to make sure that we have compatible equipment, all of those kinds of things. And so the federal government has separate grants to these different disciplines, but they have things that are called the capabilities, and some of those themes are common among the different programs. And so we work very hard to work on certain things, like, for example, communications is one of them. Things like surveillance and epidemiology, mass care, all kinds of those things are parts of each of our responsibilities. So we work very hard not only with different geographic areas, but with different disciplines of professional expertise to bring one system together where we understand the big framework and we know our roles and work together.
Mm-hmm. Now, Jim, you know, those of us in public health, you know, collaboration is part of our DNA, and we work with partners because that's sort of what public health does. But you come more from an individual patient perspective as an ER doc, you know, right. You take care of individuals. What kind of mindset change do you have to actually say, all right, we got lots of partners in there. We need partners, we need systems, we need collaboration. It must have been sort of a culture change.
It's a little different way of looking things. You know, fortunately for me, I do disaster medicine for the federal government under the DMAT, NDMS system. And so I kind of learned the way of working together there. But yeah, partnerships are very important. I think for physicians, one of the hard things is when you work in your emergency department, you're generally in charge, at least of that area, and getting used to the idea of letting go of that and working under the instant command system, letting other people deal with the command and control, and really focusing on patient care and what you need to do for that particular mission to take care of people.
Yeah. Giving up control is always hard, isn't it? Well, I want to talk about different roles, but first we need to take a little break. So we'll be back right after this message.
What if a disaster strikes without warning? What if life as you know it has completely turned on its head? What if everything familiar becomes anything but? Before a disaster turns your family's world upside down, it's up to you to be ready. Get a kit, make a plan, be informed today. Learn how at ready.gov.
Welcome back. We're talking about emergency preparedness with Jane Braun, Director of Emergency Preparedness at the Minnesota Department of Health, and Dr. Jim Harris, an emergency physician who has also been engaged in a lot of planning for emergency preparedness. Jane, you talked a little bit about roles, that came about. The feds said we need to do something. So I want to go through, what is the federal role? What is the state role? What is the local community role in all of this? So let's start with the feds. Where do they play, what role do they play in overall preparedness?
The federal government really sets the overall direction. They provide the structure, the scope, what pieces should be we working on, what are outside of our scope, and then they have secured a lot of the funding. Actually, 97% of our public health emergency preparedness in the state, at the state level, is federal money. So they do a lot of the big picture, the vision of where we are, how the structure is around what we're working on. At the state level, we work on kind of more of an assurance role, because a lot of this work needs to be done locally. We make sure that the local departments are doing the assessments that they need, that they understand what the priorities of the state are, how we want to be moving forward over the next several years, and monitoring and also providing a lot of guidance and coordination. And then at the local level, that's really where the work is done. There's the phrase, all disasters are local. And so they are doing a local assessment. Emergency management, healthcare, and public health have all done assessments in the last couple of years. What are our risks here? What are the places where we're most vulnerable? Where do we want to focus our resources? And then that's where they build those local partnerships, because these are not things you can start up in an instant. You have to have the structures in place. You have to think about, what are our fact sheets? What is our recommendation for if you're flooded? We know you can use the paper products, but what about the cans and the bottles? All those kinds of things are very hard to do just in time. And so we work on having the pieces in place so that when something happens and there's the expectation of Minnesotans that we're able to respond, to provide them information, provide them with help, that those systems are in place.
And Jim, how does the local voice get elevated into this conversation? The local providers, the local ER doc, the local ambulance crew, the local community. How do you say, these are our needs and we have to get these addressed?
Well, it happens again at the local level, and so most of us, because we work for healthcare organizations, we get involved with the emergency planning or business continuity planning for those organizations, and then usually with that you're partnering with your county government and county emergency managers, and then you kind of partner with them and come up with a joint plan. And then if there's anything you need beyond that, then you'll push that up to the state.
Right. So you had mentioned, giving up control of things, and how do we determine who actually is in control? We have, let's say we had a nuclear spill, or we had a public health emergency with, an outbreak of infectious disease, or you've got a tornado, or you've got, Jane, how do you determine who sort of takes the command in these situations?
Well, there's a couple of structures. The first one is that you handle it at the lowest level you can. And so locally, generally the first person of authority on scene begins. We have what's called the incident command system, which outlines roles for people, makes it clear who reports to whom, who communicates in which direction, who has which piece, how often you report in, you have briefings, those kinds of things. And then at the state level, there's what's called the Minnesota Emergency Operations Plan, or the MEOP, and that outlines the role of every state agency. Do they have the lead role, or are they a support role? And so we have these structures we've been building over the years where we understand who's got which piece, who communicates, how do we come together, how are decisions made, do we have one person in charge, or in a larger instance, there's a thing called unified command where a lot of people have a big role, and so they have to do the command as a group. And so it's systems we've been practicing over the last many years that are used to quickly get a handle on the situation, and they're scalable up and down as the situation changes.
So Jim, in your training as a physician and an emergency room doc, do you get training in disaster preparedness, emergency preparedness, and do you know when to sort of call for help? I think, I've been in this for a little while, so my answer from my training would be no. But I know that the programs now are including it. It is part of the training that newer physicians are getting. The incident command system is really the key, understanding that and knowing. And again, that kind of guides you on who to call and when to do it. So if anything
that we could kind of bring out. It's using instant command that really helps keep you on track and on target.
And I know relatively recently, we have the 35W bridge collapse, which was, certainly emergency medicine really needed to be involved, and public safety. And how did that play out? Like, how did that come up that let's mobilize the resources? Could you kind of walk through the framework or the scenario of that?
And again, it starts out with the first on scene, and they're doing an assessment, and then they're reporting up to their structures. And then they quickly determine what the scope is. It's, we have situational awareness, we have a size up of the situation. And so they start saying what other assets are needed here, be they for water rescue or for all different kinds of things. How many ambulances might we need? All the issues they had there with problems with not being able to get across the river or access, and how do we determine who comes in from what side, which jurisdiction, how are we communicating, all those kinds of things. And what are the roles for public health in there a little bit farther down the road. For example, they had a huge component with that on what we call behavioral health, the traumatic effects to both those affected, their families, and the responders. And who has these roles on helping these families while they're waiting to hear about their loved ones, getting information on status of those who've been taken to a hospital or those who are still missing, all of those kinds of pieces. We bring the system together. We know our roles ahead of time because we've practiced, we've trained, we know what we're doing ahead of time so that the system can work smoothly and efficiently.
And Jim, you have a practice. You're a practicing physician, so and work for an organization that you have a job to do that's part of your daily routine. How do you build this in, and how does your organization that you work for say, I'm going to give some time available to do some of this coordination for things that don't happen every day, that are sort of beyond the scope of what our responsibility is? It must take some commitment and some recognition that needs to be a community effort.
Yeah, there definitely is, and there's time carved out for myself as well as a lot of other people on our administrative team or emergency management side. One of the organizations that involved with credentialing hospitals, JCO, kind of mandates some of this stuff. So there is kind of a framework there that's laid out, and so to meet those guidelines that they lay out, we budget time and work towards those goals.
All right, and I want to talk about what you'd call some of the assets, some of the equipment that you've got in the last segment, so that people know sort of what's available in the state if they need some needs. But first, we need to take another little break. We'll be back right after this message.
Did you buy the flashlight and the batteries?
Yes.
Did you make sure we're not missing anything in the first aid kit?
Yep.
Did you go through the plan with the kids again?
Yes.
The more you prepare today, the more you'll be able to reduce the devastating effects of a tornado, an earthquake, a power outage, or any other disaster. Get a kit, make a plan, be informed. Visit ready.gov.
Welcome back. We're talking about emergency preparedness with Jane Braun from the Minnesota Department of Health and Jim Harris, an emergency room physician who is actively involved in disaster and emergency planning. When we started the program, we had that little clip from KSTP, and it showed getting together of all of the assets, all of the equipment and things. And I think people may not be aware of all of the things that go into this, and I just want to kind of go through fairly quickly what these things are. I know that you have a casualty bus, a multiple casualty bus, why do you need that, and how does that play into your disaster planning?
Well, there's actually two of them. The importance of them is to be able to transport larger numbers of patients quickly and possibly for a little bit greater distances. The one bus can do 12 patients lying down, 10 patients sitting. The other, I believe, can do 20 laying down, 16 sitting up roughly. They can take critical care patients, so they can take patients that are on ventilators. So they're really key if you ever had a mass casualty incident where you needed to transport a lot of patients, if you had to evacuate a hospital, a nursing home. They can move large amounts of patients relatively easily.
Right. And as we go through these things, are they available statewide? I mean, I know they have to be located someplace, but can they be mobilized and moved to various places throughout the state?
Yeah, all these assets that we'll be talking about are state assets. They are managed and coordinated by various jurisdictions, but through the state duty officer, it's kind of a one call, that if somebody needs these, we'll talk to them quickly, see what assets are the correct fit, and they are available for anywhere in the state that they're needed.
All right. What about the mobile medical unit? I know this is sort of like a kind of a mobile hospital, right?
Yeah. It is. The mobile medical unit is basically a 53-foot semi that is an 8-bed hospital inside the semi. Kind of equate it to an emergency department or an urgent care in general, that type of thing. But we have a lot of capacity there, being close to being a regular emergency department. And that's something that would be real useful. For example, the instance that Jim gave earlier about if a sprinkler ruined part of a hospital, we could temporarily serve that purpose in that area. Or if a tornado hit a small hospital or an emergency department, serve as that function. We occasionally, for training purposes, will do a large event really to help practice with the staff. But it's an asset that provides a level of care that's beyond what one would expect normally in a mobile area.
Yeah, I would expect that would actually be very cool. Like one of these large outdoor concert things where you have, you know, hundreds of thousands of people in heat, and it'd be a good thing to have available. And then I know that we have to also worry about alternate care sites. You know, what are the assets that we have? You know, when something closes down, you got the mobile medical unit, but you also need alternate care kind of sites. What do you use to do that?
Well, there's two mobile medical teams in the state right now. One in the central region, one in the metro region, and they both are capable of setting up alternate care sites. Generally, the alternate care sites are 25-bed increments. And they can provide critical care if needed. They can do ventilators just like the MMU would be able to, but they can set those up in gymnasium, school. One of the advantages of the mobile medical team's alternate care sites is really timing. If you look at the mobile medical unit, it takes a little time to set up. You know, granted it's very cool. It brings its own lab, its own pharmacy. Again, pretty much an emergency department with short of the CAT scanner. But the mobile medical teams are a little bit more nimble. They can get out a little bit quicker, get ahead of things a little bit. We talked about the MCI buses. One of the advantages to them is they can usually go out really quick. And so again, it's kind of the what do you need and when do you need it kind of.
And I assume all of the planning takes into account Minnesota weather, you know, particularly our winters and cold. You can operate all of these things in 20 below zero?
Yeah, we do have, fortunately, for example, on the mobile medical unit, we have an enormous generator on there that can provide power to some of the other assets. But you know, the Minnesota Ambulance Strike Team also has their tents with generator capacity and heating and air conditioning. And we did actually deploy the mobile medical unit in 2009, and we were in Moorhead, and it was down to 16 degrees. We had a snowstorm. We deployed in a blizzard, and learned that Dr. Harris actually designed a drill where we practiced opening and closing the doors and seeing if we could keep the temperature comfortable in there, and we could. And so all of these various assets are big parts of the whole, and they all can operate in a wide variety of temperature ranges and other conditions.
And then lastly among the things is the portable mortuary. I don't think people actually think through, I mean, the general population, that you need to, in fact, if some people die, you need to have a plan for how to deal with the bodies.
Absolutely.
Yeah, for a mass fatality situation, again, it's one you don't like to think about, but there's really no excuse for not having a plan. And so it's a system of 6 trailers that we have that are stored in St. Paul currently, but can be deployed anywhere in the state. And with the right facilities, say an armory or some type of thing, we can set up a very large mortuary there to deal with all the kinds of things that need to be done around identification of remains, all kinds of things like that. And then we're working on some software systems too on family reunification, notification, all those kinds of things. And so it's not something people like to think about, but we do have that capacity and capability in Minnesota too for if we were to have some sort of a mass fatality situation.
And where do you get the people to do this? I mean, we only have a limited number of emergency room docs, and who are the people that come and volunteer their time or work on these disasters in the emergency preparedness?
Well, we kind of draw from a large pool, and again, it's kind of based a little bit around timing. One of the things is mobile medical teams, and these are teams that are preformed, they're dedicated to doing this, and they're able to deploy relatively quickly. Our goal with them is to probably use them in that first 24 to 72 hours as the event is kind of unfolding. Then we can pull from the Minnesota Response Medical Reserve Corps and use volunteers from across the state to kind of fill in. And our goal is to eventually work towards using local staff to staff some of these resources. But you need to give communities time to take care of their own houses, their own families, before you can allow them to come back and start working.
Yeah. And we've only got about a minute left, but I know with tight budgets and is there concern that this training that really has been ongoing over the last 10 to 12 years, which has brought us up to a really good level, can this be sustained? And how much resources do we need to make sure that it's always there?
We are struggling with that quite a bit right now. These mobile medical teams that we've been talking about, we have developed under a Homeland Security grant that is running out this year. And so our ability to keep training and recruiting more is going to be compromised with that. With the Medical Reserve Corps, again, a lot of that is done locally. But the grants that we pass along to the locals, as we get cut, we're cutting what's there. So it is a difficult thing to sustain this, which is really a shame because we've built a system that I think people expect to be there. And it's jeopardized right now.
Yeah, and we know that disasters will occur,
right.
Events will occur, weather, traumatic things occur, so we have to be prepared. Well, thanks, this has been very helpful, so thanks for being with us.
Thank you.
And I'll be back with a closing comment right after this message. The difference between medical care and public health has been characterized over the years in many dichotomous ways, like treatment or prevention, individual or population, short-term or long-term. But as a society, we tend to lean more towards the treatment, the needs of the individual, and the short-term. But as we learn more about protecting, promoting, and improving health, we begin to understand the need to think more about prevention, the needs of the community, and our long-term health if we are to achieve our personal and societal health goals. We need to think about the structure on which our health system stands. It's sort of like building a house. You need both a strong and firm foundation on which to build an attractive and functional structure. If you put all your resources into decorating your house and skimp on the foundation, you will not have a house that will meet your needs for the long term. Conversely, if you spend all your resources on the foundation, you will not have enough to put up a structure that is comfortable and enjoyable. A balance is needed, but that balance needs to start with making sure the foundation is adequate. So it is with planning for emergencies. We need a preparedness foundation to protect our health. We need the capacity and the ability to respond to the needs that arise in the community from situations that are out of our control. We need a strong public health infrastructure on which to build that response capability. Too often, we've delayed investing resources in our public health infrastructure with the mistaken notion or hope that nothing bad will happen. The reality is that disasters and emergencies are going to be with us for a long time. So we need to rethink and rebuild the balance between treatment and prevention, between individual needs and the community needs, and between the short term and the long term. Only when we have an appropriate balance will we have a long-term security and better health. That's all for today. Thanks for watching. I hope you can join us again next time on A Public Health Journal.